This next unit will cover the two dermatologic disorders, acne vulgaris and atopic dermatitis. Both conditions are characterized by intense itching, which this cartoon clearly demonstrates. By the way, that was a joke, so you can laugh now. We will start with acne vulgaris, and this video will cover acne pathophysiology and the drug action of treatments for acne. By definition, acne is inflammation of the sebaceous glands, also sometimes called the oil glands, of the face and upper trunk, including the chest, shoulders, and back. Acne is by far the most commonly treated dermatologic condition. Acne has a lifetime prevalence of 90%, meaning that almost 100% of individuals will experience some form of acne in their lifetime. The onset of problematic acne typically occurs around puberty, and this is consistent with the pathophysiology of the disease, which involves androgenic hormones like testosterone. Acne usually subsides after the end of the pubertal growth period, but not always. Two groups of etiologic factors that contribute to the development of acne are genetics and the environment. Certainly, genetics play a role as individuals predisposed to more oily skin or who have family members who experience significant acne will likely go on to experience significant acne themselves. There are many environmental factors that can trigger an acne eruption, but in general, these environmental factors do not initiate the pathophysiology of the disease. Such environmental factors include high heat and humidity, pressure and friction, like wearing a helmet or hat or anything on the face or body, and a diet that has a high glycemic index or is full of dairy products can also predispose to an acne eruption. Consistent with the typical onset of acne at puberty, it is not surprising that the initiating pathophysiologic step in acne is an increase in androgenic hormones. This increase in androgen synthesis primarily involves increased levels of the male sex hormone testosterone, and this is present in both men and women. Androgen excess is one of the initiating steps, following which there is increased keratin production, also known as epithelial or keratin hyperproliferation. Keratin is a hair and skin protein that is found in the sebaceous glands or the hair follicles of the face and upper trunk. And this hyperkeratinization can lead to the formation of a keratin plug in the sebaceous gland. Once keratin has plugged the sebaceous gland opening, this can result in the trapping of sebum or fatty acids within the hair follicle or sebaceous gland. The trapping of sebum by a keratin plug is what leads to the non-inflammatory acne lesions known as blackheads and whiteheads. Another reason that this process occurs more frequently after puberty is that not only does androgen excess increase keratin production and proliferation, it also causes increased secretion of sebum or hyperseborrhea, and the presence of more pro-inflammatory lipids as opposed to non-inflammatory or anti-inflammatory lipids. Once this trapped sebum forms a non-inflammatory acne lesion like a blackhead or a whitehead, the process could stop there, or it could proceed to inflammatory acne if bacterial colonization of the trapped sebum is allowed to occur. There's a bacterium that's present on the face named Cutibacterium acnes, which you may also see called Propionibacterium acnes, and that was its former name. This bacteria normally lives on the face and upper trunk, and the trapped sebum is a perfect environment for C. acnes to grow and develop. If this bacteria colonizes the trapped sebum, this can lead to a large or significant inflammatory reaction that involves activation of neutrophils, and the development of inflammatory acne lesions known as papules, pustules, nodules, and cysts. In addition, these inflammatory acne lesions can burst that release their contents, including additional bacteria, into the dermis or the upper layer of the skin. This can cause additional acne lesions and contribute to a feed-forward cycle of acne development. There are 6 primary types of acne lesions. Whiteheads and blackheads are considered non-inflammatory lesions, while the other 4 are considered inflammatory because they involve an inflammatory reaction and the infiltration of bacteria. Whiteheads occur when the keratin plug blocking the sebum is still closed off to the surrounding environment and therefore appears white through the skin. A blackhead is very similar, with the exception that the keratin plug and trapped sebum have been exposed to the environment or open, and therefore the trapped sebum turns a black color due to oxidation. Contrary to popular belief, blackheads do not contain dirt, but rather oxidized sebum that turns black. Papules are considered the initial inflammatory lesion and involve closed skin and raised bumps with a red or pink area. Pustules are what people probably typically think of as pimples, and these are lesions in which an inflammatory reaction has occurred and the layer immediately under the skin is now filled with a yellow or white pus, as demonstrated in this image. Nodules and cysts are more severe inflammatory acne lesions, and these are much larger, up to several millimeters in diameter, and they contain sometimes very hard, immovable nodules or trapping of sebum, keratin, bacterial contents, and other inflammatory mediators. These lesions can be present on various parts of the body, but are primarily found on the face, neck, chest, shoulders, and back. In terms of acne diagnosis, a visual inspection of the lesions would occur, and there might be some kind of grading or staging of acne severity depending on the type of lesions that are present. There are currently 5 or more different ways to grade acne, and depending on the clinic, they may use a different grading or classification scheme. Therefore, the one that I am showing you is just a general way to classify acne as mild, moderate, or severe. Mild acne is typically considered the comedonal type, which is also known as non-inflammatory type, when the comedones or lesions are the primary lesions found, and these would include whiteheads and blackheads. There may be a few papules and pustules, but these would be few in number and also small in size. Mild acne would not have any nodules or cysts present. In moderate acne, there would certainly be the typical whitehead and blackhead comedonal acne. And in addition, there may now be several papules or pustules and possibly even nodules. In moderate acne, there is anywhere from 10 to 40 classic whitehead or blackhead comedones. There may be around the same number of papules or pustules and up to 10 nodules without any cysts. One thing to note about this table is that these numbers are for identification of lesions on the face and not throughout the body. Severe acne is characterized by nodulocystic acne, where there are several comedones, many of which may be fused together, at least 40 papules and pustules, at least 10 nodules, and many nodules and cysts. The grading or staging of acne is important because it dictates what treatment options would be tried as initial or first-line therapy. Next, we will move on to talk about some of the agents that are used in the treatment of acne. In general, the drug action or mechanisms of acne treatments involve reducing or blocking one of the 4 primary mediators of acne pathophysiology. The first initial step that I talked about was increase in androgen levels. And there are some agents that are able to decrease androgen synthesis or signaling. The next is increased keratinization or hyperkeratinization. Several agents are available to reduce this abnormal keratinization. In addition, we have increased or abnormal sebum production, and again, there are several agents that target abnormal sebum as well. Next, you have bacterial colonization by C. acnes, and there are several agents that can reduce the proliferation and colonization of that bacterium. And finally, there is a group of agents that reduce generally an inflammatory response. Many of the agents listed on this slide have been covered previously in terms of their mechanisms or pharmacologic classes. Therefore, I will focus this section on 4 specific treatments: salicylic acid, benzoyl peroxide, the topical retinoids, and isotretinoin. I will only briefly touch on agents that have been covered elsewhere, which include the hormonal therapies, antibiotics, and corticosteroids. First, we will begin with salicylic acid. Salicylic acid is considered really only mildly effective in the treatment of acne, but in most cases it doesn't hurt and therefore is a good recommendation in terms of a good cleansing and cleaning procedure. Salicylic acid is part of the salicylate family of drugs, which includes aspirin. And its mechanism in acne is that it is able to reduce hyperkeratinization by interfering with adhesion between epithelial skin cells. This causes those cells to become non-adherent to one another, and they slough off or undergo what is called desquamation. Salicylic acid is a topical treatment for acne and is typically available in concentrations ranging from 0.5 to 2% for acne treatment. The primary interaction with salicylic acid, even though it is administered topically, is to avoid combination with other salicylates like aspirin, because high levels of salicylates in the body can lead to salicylate toxicity, which can cause various acid-base disturbances. The primary adverse effects associated with the use of topical salicylic acid include hypersensitivity reactions or salicylate allergy, as well as some local irritation where it is applied. As I mentioned earlier, this is really only considered mildly effective for acne, and so it is recommended for mild acne only, and it is available over the counter. Usually in over-the-counter products, you will frequently find salicylic acid in combination with benzoyl peroxide or BPO. The next topical acne treatment is benzoyl peroxide, also abbreviated BPO. Benzoyl peroxide has several mechanisms by which it is able to reduce acne, as it interferes with several steps of the acne pathophysiologic process. It also reduces hyperkeratinization by interfering with cell-cell adhesion. Benzoyl peroxide also reduces bacterial colonization and decreases the synthesis and release of the irritating or pro-inflammatory fatty acids by releasing free radicals in the sebaceous gland. As a peroxide, it is able to oxidize bacterial proteins and fatty acids to reduce their effect in generating an acne lesion. Benzoyl peroxide is available over the counter in strengths ranging from 2.5 to 5%, again as a topical therapy. One of the potential interactions with benzoyl peroxide is photosensitivity, and therefore sun exposure should be limited whenever BPO is being used. Other adverse effects include a possible hypersensitivity or allergic reaction, the presence of dryness or irritation because benzoyl peroxide is very drying and irritating to the skin. And as a peroxide, it can also have a bleaching effect on clothing, towels, and hair. In mild acne, it would be available over the counter and is really the most effective OTC treatment for acne. It is also available by prescription in combination with the topical retinoid adapalene or the antibiotic clindamycin. And this would be relevant or useful for more moderate acne. Next, we have the topical retinoids. One note about the topical retinoids is that these are NIOSH hazardous drugs, so they do require special handling considerations. The topical retinoids are all vitamin A derivatives, meaning they are very structurally similar to naturally occurring vitamin A. And specifically, they are able to stimulate the same receptors or transcription factors that vitamin A is, like the RXR or retinoid X receptor. As demonstrated in the schematic on the right, the retinoids like tretinoin and adapalene compete for binding to the RXR retinoid receptor, which is an intracellular nuclear receptor that can then translocate to the nucleus, bind DNA, and induce gene expression and repression of various proliferation and differentiation and immune genes. The net effect of this activity is to reduce hyperkeratinization by decreasing cell adhesion and increasing cell turnover or differentiation. The two primary topical retinoids available are tretinoin and adapalene or differin. Tretinoin is available as a topical cream, gel, and lotion, whereas adapalene is available as a topical gel. At 0.1% concentration, it is available over the counter. At higher strengths, it is available by prescription only. The topical retinoids are contraindicated in pregnancy, even though they are administered topically and absorption to distant systemic sites is likely limited. They should still be avoided in pregnancy due to the risk of fetal harm. They also can cause photosensitivity, so sun exposure should be limited, and they can increase the irritating effects of salicylic acid, and so they should not be used in combination with one another. Other adverse effects include hypersensitivity or an allergic reaction, photosensitivity, as I mentioned, and also the possibility of dryness or irritation. Tretinoin is available by prescription only and is helpful for mild to moderate acne. It is also available in combination with an antibiotic. For mild acne, adapalene is available over the counter in 0.1% strength. For mild to moderate acne, there are higher strengths of adapalene available by prescription. The last acne treatment I will talk in greater detail about is isotretinoin, which is essentially the oral form of tretinoin or retinoic acid. Isotretinoin is also a vitamin A derivative and is able to stimulate the RXR receptor by the same mechanism that I described previously for the topical retinoids. The main difference between isotretinoin and the topical retinoids, however, is that isotretinoin is delivered as an oral capsule. It has a very similar mechanism of action where it is able to reduce hyperkeratinization by decreasing cell adhesion and increasing turnover, and it is also able to decrease sebum production. Oral isotretinoin is associated with severe and significant teratogenicity and fetal harm, and therefore it should not be used in pregnancy. There is a very detailed REMS program that goes along with isotretinoin dosing, in which women of reproductive age are required to demonstrate negative pregnancy tests prior to, during, and after a course of isotretinoin therapy. In addition, vitamin A supplements and steroids should be avoided or limited when an individual is using isotretinoin because they can decrease the effectiveness. Sun exposure should also be limited because isotretinoin can cause photosensitivity as well. Other adverse effects, in addition to the severe teratogenicity, include very dry skin, lips, and eyes, which can sometimes make contact wearing difficult. Increased cholesterol levels, and specifically triglycerides, and these do need to be monitored during isotretinoin therapy, as well as various side effects that can occur due to the vitamin A activity, such as back pain, some arthritis-like symptoms, the potential for bone mineral loss and osteoporosis, and ocular dysfunction. Because of these significant side effects, despite its effectiveness, isotretinoin is really only reserved for severe refractory acne that is not assisted or reduced by any other treatment. It is typically administered in a 15 to 20-week course, after which there would be a break from therapy before potentially returning at a later date. The additional acne treatments here that I mentioned, I will only briefly cover as these are discussed in more detail elsewhere. The first are hormonal therapies. One of the ways that acne can be reduced is by anti-androgen therapy, and specifically the use of the aldosterone receptor antagonist spironolactone. In women specifically, the use of spironolactone can have anti-androgenic effects and reduce the initiation of acne pathophysiology. Spironolactone is not FDA approved for acne, but is frequently used off-label in women with good activity. Also, because estrogen competes or sort of antagonizes the effects of androgens, the use of an oral contraceptive that contains estrogen is also effective in acne treatment in women. And this is especially true if the acne is associated with the menstrual cycle or if the individual has irregular menses or some other symptoms of androgenic excess. And in that case, an estrogen containing oral contraceptive would be useful. To control the colonization and reproduction of the C. acnes bacterium, there are also several topical or oral antibiotics that can be used. As far as oral antibiotics, minocycline is typically the preferred or choice oral antibiotic, although other tetracyclines like doxycycline or sarecycline can be used. Specifically, sarecycline is only indicated for non-nodular moderate to severe acne. Some side effects associated with the use of the oral antibiotics include photosensitivity, rash, harm to the fetus, and possibly permanent tooth discoloration. For topical antibiotics, clindamycin is probably the one that is seen most frequently and typically in combination with benzoyl peroxide or one of the topical retinoids. Erythromycin is also sometimes seen as a topical antibiotic, but is used less and less due to the development of resistance. And lastly, corticosteroids may be used to reduce the inflammation associated with inflammatory acne. And these are typically topical corticosteroids, but oral corticosteroids could be used if they were indicated. When using corticosteroids for acne, it is typically recommended to always use the lowest potency corticosteroid first, which would be to start with hydrocortisone and work up from there if higher strengths or potencies were needed. I will talk more about the topical corticosteroids in the dermatitis video. Now is a great time to pause and review what we've learned about acne pathophysiology and drug action. Based on what we've talked about in terms of the etiology and the treatment options, take a moment to list some factors that may be important when you're counseling a patient with acne, including ideas like triggers, cleansing regimens, over-the-counter products, etc. And you can take a picture of the QR code here to help you answer this question.